are lucky to have Dr. Edward Gottesman providing his experience to date with Gintuit, and he's going to go over several of his cases and include some of his learnings as well as show us the outcomes from his materials. And as Ken said, if you have questions as we're going along, please raise your hand and we will keep track of that. And in the meantime, we will go ahead and let Dr. Gottesman start so that everyone's time is being used to the best that we can. Okay, Dr. Gottesman, thank you if you'd like to start.
Thanks, Peggy. Hi, everybody. Thank you, Organogenesis, for having me. I appreciate the opportunity, and I'm frankly very humbled by this. So let's get into it. I've got around a little over 50 slides here that I wanted to comment on, and I know that Ken mentioned that at the end we'd probably open up the discussions for questions and answers. So hopefully we can make this as interactive as possible, and I think that's the benefit of doing it this way. So let's get into it. As we all know, Gintuit is intended for oral keratinized tissue regeneration. From the company's marketing, we know that this is an allogenic cultured keratinocytes and fibroblasts in bovine collagen. In addition, we know that it's indicated for topical use, not submerged, and it's to be applied to a surgically created vascular wound bed in the treatment of mucogingival conditions in adults. And I also understand that there are some initial work into determining where a product like this could serve an adolescent population and a population of patients who may be currently undergoing orthodontics or soon exiting orthodontics, and seeing how this can benefit that population as well. So just to sum this all up early on, I had first attended this Gintuit calibration session in the summer, August of this year, this past year. I treated my first case roughly a month after that in September. Since then, so for the last 6 months, I've treated a total of 10 patients using Gintuit, all of whom were missing keratinized tissue and who had an inadequate zone of attached gingiva. So the total number of teeth were 11 teeth, and in 3 of the patients there was 2 teeth per patient, and in the additional 5 patients, those were all single teeth treated, and there was a single implant case that we had treated as well. Of the total number of teeth treated, there were 2 cases where I felt that the results were really, I'll say, ineffective in increasing KT, but I also attribute that to poor case selection. And I should mention that in the case that we lost, or not lost, but that we didn't attain an increase in keratinized tissue, that patient had undergone free gingival grafting prior, and in that situation it didn't have any success in increasing the zone of keratinized tissue then either. So this was a retreatment of a failed free gingival graft. So looking at that case, I can tell you that it's probably because of poor case selection. This patient had almost no vestibule to speak of. And finally, there's a single implant case, which, as you'll soon see, resulted in what was somewhat unexpected coverage of the implant surface. My first patient tonight is a 20-year-old female with a significant health history of jaundice at birth. She's penicillin allergy, and she currently takes oral contraceptives. Her dental history is significant for some recession on number 24. This is a girl who's in college, and so she travels back and forth, tries her best to maintain her maintenance visits, but as you'll see, her hygiene could be improved, and her frequency of maintenance care as well. And she presented with 1 millimeter of an attached keratinized tissue remaining, and there really wasn't any attached gingiva. And the rationale here was to increase the zone of attached gingiva to protect the tooth against additional resection. So this is her smile line, and this is her retracted view. And at baseline, as you can see, that she presents with essentially 1 millimeter of keratinized tissue, which is unattached on number 24. And so the probe essentially read about 1 millimeter pocket probing depth, which I think was just on top of the attachment apparatus. And so whatever whatever keratinized tissue you see there is essentially unattached. So there's no attached gingiva here. This is a closer view of that, just to show you that this is a chronically inflamed site, and also you can appreciate that her home care could be better. She develops calculus and comes in every 6 months for maintenance. She probably would prefer to come in more frequently, but she does have a hard time coming here because she's far away at school. And when we decided to ultimately treat her, she came in, spent the weekend, went back to school, and so getting her back for follow-up wasn't easy, but we have a little bit to show you. Here we are soon after infiltration of the area with a local 1 to 100,000 epi. And the incision design was such that it was, I'll go back a slide, essentially the incision was made at the mucogingival junction, and the mucosa was prepared with split thickness dissection. You can see that the envelope flap, or the straight line incision, was pulled away here when we retracted the lip, and we were able to prepare a wound here to facilitate the placement of the living cell construct. The application of 6-cell chromic sutures was used to secure the material in place, and it was done sort of peripherally to stabilize the living cell construct. And additionally, it was done more deeply at the apical extent to secure it apically as well. Also note that the margin of the keratinized tissue was preserved. It wasn't excised, as I felt it would benefit to have as much peripheral keratinized tissue to help in the secondary wound healing. The healing about 29 days later looked as follows, and this was the first case I had done, and frankly I wasn't very impressed because I thought to myself this was something that resembled a scar or an apical fibrosis of some sort. But I can tell you, having done more of them, that in looking back at this case now, I was more comforted that this was in fact keratinized tissue, and I think that the illumination here of the flash gave this a little bit more of a scar-like appearance than really there was. Again, look at her home care. There's a lot to be desired here, but it's for this reason I felt that this is a patient who needed to have a procedure like this done because she has compromised hygiene, and especially in patients like this, we'd like to see a thicker band of keratinized tissue to protect the perineal tissues from further breakdown and recession. What we ended up seeing here was about a 2 millimeter increase in attached gingiva. So earlier we saw that there was a 1 millimeter keratinized tissue margin unattached, and here we're seeing at least 2 millimeters of attached tissue. This is a little closer view of that case. And if we look at the side-by-side comparison, I think we can really appreciate that there's a thicker, wider, a total 3 millimeter zone of keratinized tissue on the right relative to the left, with probably 2/3, 2 millimeters of attached gingiva and maybe a millimeter still of keratinized tissue. My next case is a 77-year-old female with high blood pressure, and she has a unique phenomenon of polycythemia vera, which is an abnormal increase in the red blood cells. This was not a contraindication to surgery. As far as allergies, she was allergic to codeine and sulfa, and took several medications which had no impact on her surgery. And her dental history was that she'd been seen every 3 months for maintenance. This was a patient in my maintenance practice, and she presented with gingival recession on tooth number 11 with less than a millimeter of unattached keratinized tissue remaining. And here, similarly, we intended to augment the zone of keratinized tissue with the intent to protect this tooth from undergoing further attachment loss or recession. So here's the clinical presentation at baseline, and we can see that she has less than a millimeter of unattached keratinized tissue. Again, the probe here measured to a millimeter probing depth, and that attached tissue, or sorry, that keratinized tissue on the buccal of number 11 is maybe a millimeter. So whatever tissue isn't attached is keratinized. Again, very little, if any, attached gingiva, and so the rationale was to increase the zone of attached gingiva. Up close, you can really appreciate that this is, in fact, mucosa. You can see that vascularization up close, and arguably less than a millimeter of unattached keratinized tissue. So similar to what you'd seen earlier, the incision design was such that we marked the mucogingival junction and went about 1 tooth mesial and distal and split thickness dissection. And here again preserving the zone of keratinized tissue that was remaining without including that in the incision. I didn't want to risk losing more tissue or increasing the recession. And the next step was to prepare our material, the living cell construct, using the Z-fold. The material was sized to essentially overlap the incision margins, probably by 1 millimeter or 2 millimeters in every dimension. And again, suturing with 6.0 chromic gut sutures. Most of these are interrupted, and then through the body of the living cell construct, I just tried to tack this down to whatever periosteum that we were able to preserve, trying to approximate the material to the wound bed as much as possible. And I just sort of began to do it this way. I know that it's been demonstrated that we should use some sort of sling suture to cover this and from the periosteum, but this is something I just gotten accustomed to doing using 6.0 thread and a very small P3 type needle. So I don't really use suspension sutures. After that was performed, in this case anyway, I used a 4th layer. I was still, this was like my 3rd or 4th case, and I was just trying different things, and I thought I would try the 4th layer here, and that's what we see now. This was about a week after healing. We see that the tissue is a little bit raw. It's erythematous healing. Of course, there's this little perforation you can see here, but if you look at another couple of days, another 7 days later, 14 days later, I was very comforted to see that we really increased this zone of keratinized tissue considerably. The mucogingival junction, the new mucogingival junction was reestablished, certainly at least a few millimeters apical of where it had been earlier, and the tissue appeared healthy. And this was, in my opinion, a very successful outcome. And I think probably I would submit that this was a better outcome than I would have achieved with a free gingival graft. And here's a closer view of that tissue. You can see the texture and the color are a good match, and I don't think that this would ever be suspect of having been grafted in the past. And this is 35 days, so I had about a month post-op on this patient to show you that this was a good stable result for at least a month with a very good tissue texture, color match and texture match as well. So probably upwards of 4 millimeters of increase in keratinized tissue. If we agree that we had 1 millimeter originally of keratinized tissue at the margin, and we have a total of 4, that means we probably gained 3 millimeters of attached gingiva. Next case, this is also a 70-year-old female, and she's has hypertension, increased high cholesterol levels, history of mitral valve prolapse, and arthritis. She's peanut allergy. She takes numerous medications. Her dental history was that she had moderate bone loss and gingival recession on tooth number 24, with less than 1 millimeter of an unattached keratinized tissue remaining. So this is very similar to a case we'd seen earlier. The difference here is that this is a patient with bone loss. So, we're not going for root coverage, we're going for augmentation of KT. So having bone loss probably won't affect our outcome expectations as it might have if we were doing root coverage. And also she has a lower incisor splinted with a wire retainer. And once again, rationale here is to increase the zone of attached gingiva in an effort to protect the tooth against additional attachment loss in the form of recession. So here we are. This is a patient who has good home care, also good maintenance follow-up. She does develop calculus buildup and needs to be seen quite regularly, but you can see that this tooth is a little more prominent in the arch, certainly facially positioned relative to 25, and that may be part of the reason we see this defect, this mucogingival defect, in addition to the fact that we have somewhat of a high frenum attachment, somewhat of an aberrant frenum attachment. And so the goal here was to augment this unattached keratinized tissue, this millimeter of unattached keratinized tissue, on number 24 with, in addition to a frenectomy. So we, again, approached this with a submarginal incision and excised the frenum and did a split thickness dissection, preserving as much periosteum as we were able to. And just the way I'd done it in the past, I'm using 6-0 chromic sutures and essentially stapling this in place with interrupted style suturing, first coronally and then more apically, and also into the body of the living cell construct. And here I don't have the intraoperative view of the additional suturing that was done. This was sort of the initial level of suturing we performed. But this was the outcome. So this was a little over 2 weeks, and if we look at the side-by-side of this, well, here you can see 2 millimeters of increased keratinized tissue, and side-by-side I think you would agree that we've achieved at least 1 millimeter more of keratinized tissue, if not 2, and certainly that is in the form of an attached gingiva. So we had keratinized tissue, we still do. We increased it by maybe 1 millimeter to 2. And that's more apically where we need it at the increasing the level of attached gingiva. So this is 16 days. Now this case is a case that I tried to be a little bit heroic with, and the patient was sent to me for free gingival graft on number 19. This is an implant placed by another operator, not myself. The dentist inherited the patient and had a temporary crown in place, and wanted to have this implant grafted with keratinized tissue before finalizing the crown. She's a 38-year-old female with occasional migraines, and she takes Gintuit for hypothyroidism. And the implant was placed about a year ago, and I understand this is a Nobel BioCare implant. I did a little bit of background check on it. I don't know. It looks like a 5-millimeter wide body platform. But I can't be certain without having spoken to the implant surgeon about this. But in any event, she presented with recession on the abutment and exposed implant abutment surface, and very little, if any, attached gingiva. It's hard to say that there was any gingiva at all, and you'll see that in a second. And once again, just as we'd seen prior, the goal of therapy was to augment the zone of keratinized tissue, especially that of attached gingiva, in an effort to protect this tooth, or this implant rather, from any further attachment loss and recession. This was the baseline presentation, and what you're looking at is, after speaking to the dentist who did this, was working on this crown, he said he prepared the abutment in the mouth, and I believe that that's the prep that's on the abutment that you're looking at with a provisional crown that's not gone all the way down. So he wanted this surface to be covered, which was never my intention. My intention was to increase that keratinized tissue layer or zone so that this wouldn't get worse over time. This, to me, looked like a mucosal margin, from the mesial line angle to the distal line angle, essentially. So baseline, I'd say less than 1 millimeter of keratinized tissue, if at all, on the implant's abutment surface. And I didn't take a picture of this case, although I really wish I had, but what I ended up doing was similar to the way I'd done it in the past. I'll go back a slide. My incision ran from, probably the distal line angle of 20 till the mesial line angle of 18 in a straight line fashion. And in this case, because there was no attached gingiva at all, I felt I would just split from here down, and there wasn't anything really to preserve. So the living cell construct was applied just as you'd seen in the past. And I saw her 2 weeks, no, a month later. I saw her 2 weeks later, and I didn't take a picture because I was sort of rushing, but a month later I got her back and took this photo, and I was surprised that this is what we found because, I can't say for sure that this is keratinized tissue, but it looks like it may be. And I can't say for sure that it's attached, but I would assume it may be. And that's because I didn't probe it. But I sure will. When this patient comes back, I'm taking more photos, and of course I'm going to definitely probe this area in a few months. But I'd be interested to see what the quality of the tissue is like in time, and what the tone and the texture and the color of this tissue will be over time. This was obviously an unanticipated result. So we started out with no keratinized tissue. We probably gained 1 millimeter or 2 here, and maybe that's attached, maybe it's not, I don't know. But it's an interesting phenomenon, and maybe it may have something to do with the fact that that surface was rough or rough-in by the burr. And so there's a lot here we can probably talk about later. Here's my last case. And this case is going to be 2 teeth done in the same patient. And she's 40 years old. I just treated her probably 2 or 3 weeks ago with occasional sinusitis, no medications, no allergies. And significantly, she has slight horizontal bone loss and gingival recession on tooth numbers 11. And number 11, she has 2 millimeters of keratinized tissue remaining, of which 1 is attached gingiva. And then on number 27, she has slight horizontal bone loss, again gingival recession, and here maybe 1.5 millimeters of keratinized tissue, of which 0.5 millimeter may be attached. So once again, the rationale was to augment the zone of attached gingiva in both these teeth. Here's her smile line. So obviously this is not an aesthetic issue. It's one for maintenance of periodontal health. This is her retracted view, and if you look at 11, you can begin to really see that if you run this mucogingival line, it's sort of lost here. It's not as obvious here, but we'll get a closer look at that. And similarly here, there's a mucogingival junction, and it's somewhat more faint here and becomes a little bit more clear in the front. Closer view, again, it's tough to see it, but what I did in this case is I'd ordered ahead of time a staining solution, which was used in the pilot study and in the pivotal study, I understand, to try and mark the mucogingival junction. So it's a Schiller solution. You can order it as long as you make a statement as to why you're using it. In my case, I said I was using it to stain the oral tissues for gum grafting. But any lab pharmaceutical company can provide you with this. And this is a 2% iodine solution, which I understand will stain any glycogen in, and that's mostly found in the mucosa, and it's absent in keratinized tissue. So we can sort of make out this line a little bit more clearly with this staining agent. And what I was also able to demonstrate here after we anesthetized this area and applied some pressure by pulling this tissue down more apically, you can get this fold in the mucogingival junction too. So there we might say there's 2 millimeters of keratinized tissue. Now this probe's about 1 millimeter, so that means we probably only have 1 millimeter of attached gingiva. And my intention was, just to go back here, was to give her a little bit more of a normal mucogingival junction, which would be a little bit more balanced from here to here. So that was my rationale, again, to protect the tooth over time. So just as I've done in the past, I'm using a single incision in the mucogingival junction, and I'm essentially trying to, at this point, before I even go into preparing the living cell construct, tacking down this secondary flap apically, and that makes it easier to suture the living cell construct, and it just makes it a little bit easier to manage the site, I feel. It may also have an improved effect on retaining this margin where it is, and so that it doesn't rebound on you. But this is something I'm trying to do more regularly, is to tack down this secondary flap apically before applying the material. Again, we've preserved as much periosteum by doing a split thickness dissection here, and again, probably going back about a tooth on either side, and that makes it easier to retain this secondary flap by extending more mesial and distal. I think it makes it easier to keep this tension free up high. So here we've prepared the site, and I mean the Gintuit. What I've done in all these cases, and I didn't really say this before, is I always once I Z-folded, I always tack down the 4 corners with 6.0 chromic. It just makes it easier to manage this when I'm doing all my additional suturing, and I'm not finding this living cell construct is difficult to manage because it's not unfolding on itself. It's acting like a tissue, like a graft. So this just helps with the handling, I feel, and it's a nice, neat little trick that I spend an extra 5 minutes, but it probably saves me 15 or 20 minutes of operative time. And just as I demonstrated before, I'm using a lot of 6.0 chromic here just to really ensure that as many of these cells that are grown on this collagen layer are in intimate contact with the underlying periosteum. So, and in this case, we probably are going past the margins to some degree. In some of the other earlier cases, I wasn't doing it this way. I was staying within the confines of the prep, but here I've gone a little bit beyond the margins. I'm not so sure how important that is, but I know that some of the representatives had said that you can try doing it this way and see if you see a difference. I have not yet, but here we are 20 days later, and I was very pleased to see that we've certainly, this was obviously 3 weeks ago that I saw this patient, but we've really, I feel, improved the quality, the texture, and matched the color very nicely of this tissue at this point, and really given her a nice zone of keratinized tissue, which I think is healthier and certainly going to protect this tooth, I feel, for years to come. And if we said that we had 2 millimeters before and now we're somewhere like 6 millimeters altogether or 4 millimeters altogether, then we've really done a nice job of augmenting this attached gingiva. So maybe 5 millimeters of attached gingiva if we say that there's about 6 millimeters of KT and 1 millimeter of probing depth. So there's the before on the left and the after on the right. And in the same patient, in the same session, since I had enough material, I did the same thing on number 27. Again, we stained this as much as we could to delineate the mucogingival junction, which I think it shows up nicely here. And we can see that when we prepared this, we again did a linear incision. Everything okay? Yeah. Can everybody hear me okay?
Yeah.
Okay, I'm gonna keep on going, and we essentially continued this single mucogingival junction incision about a tooth behind or posterior and less than a tooth forward. But again, I was able to get good stability of this apical margin with 6.0 chromic gut sutures, and was able to tack this down onto the existing periosteum, exposing this periosteum above for reception of the Gintuit. Again, we can see the typical approach was I'm trimming away probably 15 or 16 or 17 millimeter horizontal by something like 6 or 7 vertically, and it's going to overlap this if you just lay it down this way, but I tend to tuck it in, and I get a little more redundancy, but I think that's healthier because this is essentially a cell-based therapy. So my feeling was that we're delivering more concentrated cells to the zone of interest, and so this is the approach that I took here. And again, using 6.0 chromic gut sutures, we were able to consolidate the graft into the wound bed. And this was 20 days later. We demonstrated again an increase of about 2.5 millimeters of attached gingiva. So if we say that we got 4 millimeters of keratinized tissue, and 1 millimeter of that is sulcus depth, we have an additional 3 millimeters of attached gingiva that we've gained post-operatively. And those are my cases.
Great.
So,
can you hear me?
Yes, I can.
Okay. I have a question for you. You did almost a very similar case on an elderly person and on a young person. Did you notice any difference in the healing? I realized that you weren't able to see the young person on early healing, but was there any difference? And there was a different level in hygiene, but
yeah, No, I didn't. I mean, anecdotally, I've had patients that are in their 60s that probably heal better than some of my patients who are in their 20s. I don't know what the science is behind that, and I mean, I know probably it's accepted that younger patients heal better than older patients, or more mature patients, we'll say. But it's not something I'm really 100% sure occurs every time. And in the experience that I've had so far, I can't say that I see a difference. I see good healing in my 50 and 60-year-old patients, and I see the same in my younger patients, and I see sometimes poor healing in my younger patients too. So I'm not really able to give you a good answer as to what the trends should be.
Okay, and we have a question from Jessica Ellis, and the question is, one second case seems to have recession. Comments?
Let me go back. So my second case, let's see.
Hey everybody, this is Ken. I'm sorry to interrupt, but I'm going to go ahead and take the clinicians who are in the audience off mute as long as there's no background noise. If we hear background noise, I'm going to have to put you on mute. So you're welcome to go ahead and speak out your questions if you have any, although to Dr. Canales' point, if you want to send questions, you can see Peggy can read them. That's also another way. But just so you know, in just a second, I'll take everybody who's a clinician.
Okay. I guess this is the second case. So, Jeff, are you there? Is Jeff going to come online, or should I just comment? Hello? Can everybody hear me?
I can hear you.
Okay, I see Jeff is, looks like his mic's working. Jeff, are you able to hear me? Somebody said I don't have voice access. Oh, Jeff said
hear you fine.
That's
okay.
voice access.
Oh, I can hear but not speak. Okay. All right, Jeff. Is this the case, though, that you're thinking of? Maybe just... Lower canine. Okay, hold on. Let me go to the bottom. Last case, lower canine. Let me go to that.
Case. Okay, and he doesn't have voice.
Okay, that's all right. I can read what he's writing, so that's good. Let me go to the last case,
okay.
And we'll have a look at this. Last case. Okay.
Sorry, I didn't get
the
responses.
Okay. Yeah, I would say that we may have, yep, we definitely lost about 1 millimeter of tissue there. I can see that, Jeff. Let me just go back and look at this case when I designed it to see if I'd done anything that might have, well, I would probably have been happy to see that I preserved as much of this as I could have in the incision. So this is, I would say, pretty liberal of a margin. I mean, some of the other cases I didn't leave this much at all and didn't have recession, whereas here I did. And let me look and see if I possibly pulled on that. Well, maybe that's what happened right there. I think maybe that's what, if I look back at the case now, in hindsight, this may have been what the culprit was. I might have thrown a suture in here that was a little taut, and that may have been apically tugging on this margin, leading to that. So I will thank you for pointing that out because that's important. But I wouldn't, I would say that's more iatrogenic. Yeah, there you go. I'm guilty, but I wouldn't say though that it had anything to do with the material, or obviously I would take complete responsibility for that one. But you know what? That's good. I mean, that's why it's good to do this.
Yeah, he does have an additional question here. He does say, in rationalizing the treatment to patients or referrers, does an increase in the keratinized tissue perhaps balance minor recession? And then Carl Zarin is asking, how is the root surface managed?
Okay, so to answer you, Jeff, I mean, I certainly wouldn't want to make a habit of increasing recession and augmenting the zone of keratinized tissue. I think this is probably, hopefully anyway, more of a unique scenario. But yeah, I mean, I would say that it's better that I think still we benefited from this patient undergoing this procedure. But yes, I would like to try and avoid causing recession. Now, as far as managing the root surface, I didn't do anything to manage the root surface because we hadn't attempted root coverage. I mean, if we're not talking about root coverage here, but when I do my root coverage procedures, I don't do much in terms of root conditioning, and that's just because that's what I was taught. I was taught from the literature that there isn't much evidence to support its use in pre-grafting. But in these cases, we're not going for root coverage, so it doesn't really play into my approach, since most of this work is being done apical of the existing margin or apical of the bone, of the bony crest.
Great. So I have a question. In general, your approach is to manage if there's enough keratinized tissue. Do you get a gut feeling that there might be too small of a zone of keratinized tissue, like a 0.5 millimeter? Would you be more prone to maybe remove it? Are you concerned about maybe like you said in this case, seems like maybe you accidentally pulled on it. But is there a cutoff of how much zone before you remove it?
I would probably say that I would preserve every ounce of keratinized tissue that I have. So, most of the patients we're treating are patients who have limited, if any, zone of attached gingiva, and therefore very limited keratinized tissue. So, there probably will never be a patient that has 3 millimeters of keratinized tissue that I treat. I probably of all the cases I've shown, the one that I treated that had 2 millimeters on the canine in the upper left, that was probably a borderline case I would have selected to have treated going forward. So, in other words, it takes 2 millimeters or less of tissue for me to really approach this with this rationale. So, if I have a millimeter of probing depth and 2 millimeters of keratinized tissue, and that means 1 millimeter is unattached, 1 millimeter is attached. So, if I only have 1 millimeter of attached gingiva, and that margin is hard for the patient to keep clean, or they just don't have good home care, they don't have good access to professional maintenance. I mean, that would be the rationale that I would use to treat that patient. Now, if I have a patient who has 2 millimeters of keratinized tissue that's healthy, that's maintained, that patient shows good home care, I probably would select that case for watching for change and say to them, we can keep an eye on this and see if there's problems with maintaining it and maintaining it healthy, and only then would I act. So that's sort of my sort of thinking process behind which cases to select. So getting back to your original question, if you have very little attached gingiva left, very little keratinized or attached gingiva left, and you're preparing this site, I would probably preserve every millimeter of tissue that I could, so that we don't increase recession, and so that we have a keratinized bed to help feed whatever cellular activity it can to the recipient site.
Okay, great. And so,
Eddie.
Yes.
Yes.
Yeah, Eddie. Yeah, this is Jack Spitznagel. Just very quickly.
Hi,
Carl has a series of comments that he followed on his original question with.
Okay.
And I assume his first question regarded that same case that we've been looking at. And he asked if there was any attempt to gain attachment coronally.
No, that's not the attempt that I made here, because that's sort of not the indication for this product. I mean, we know that it increases keratinization. We know that we need an existing vascular bed in order to achieve this result. So I don't think that, and I don't think that we would gain root coverage necessarily with this with Gintuit. I however would say that going forward, if I was going to attempt a root coverage procedure, which I typically will use human collagen tissue, donated human collagen tissue, I may elect to augment the zone of keratinized tissue in advance of doing any coronal position flaps with using acellular dermal matrix. Most of you know what that is. But that's where I'm beginning to see the application of Gintuit in my practices. I've done a lot of the acellular dermal matrix grafting for root coverage, and I'm pretty happy with the results I've gotten. My only criticism has been that when we do those in cases of shallow zones of keratinized tissue, we see resulting from that shallow, narrow attached gingival margins or zones, and I'd like to maybe augment that in advance of the root coverage procedures, so we'll have what might appear more normal once it's been completed. But I haven't done any cases like that yet. Yeah.
Yeah, I know we talked about Carl's next question when you showed me the photograph of the implant case the first time. And his question is, how do you explain the root coverage or the implant coverage that you got on that case?
I don't have an answer. I knew somebody would ask, and I don't know. I want to get this patient back because I'd like to get another look at it, get another picture of it. I'll bring it back on the screen. It's peculiar how this tissue looks, because it may look like it looks almost like it's unattached. But I mean, I won't know until I go in and probe it. I don't know if it's because we've just traumatized the wound and we've allowed for epithelium to migrate over a roughened implant surface, or rather over a roughened abutment surface. Maybe the surface lended some help here and allowed for the tissue to creep over it. If you look at what happened here, it sort of came to the polished collar.
Yeah.
And it stopped. So this sort of bridged here. So I don't know if this is possibly to credit for the result. I would love to say that it was this, but I don't have a good answer. I only know that this was not my intention. I was really just trying to get whatever was happening in this area to change tissue texture and color, but not here. So
right. I think what we talked about, my kind of alternative hypothesis on that was that you may be having some tissue retraction across that area that's just causing an ellipse to shorten itself.
Maybe. Yeah, maybe if you pull on this with a Minnesota retractor here, maybe that'll pull down. That is possible. Looking at this, it seems a little bit more relaxed. Looking back, it seems a little bit more pulled. But I don't know for sure until I get her back and take this photo one more time. But that is possible. I'm going to have the same assistant use the same Minnesota retractor just so that it's.
Yeah, that's going to be very interesting to see how that turns out. I'll be fun. By the way, Carl ended his questions with a comment, and he said, "By the way, your results are admirable." Which
thank you.
I agree.
Thanks, Carl. Appreciate it.
And then Jeff has another comment asking, have you compared Mike Black's fuse suture technique to your dense suture technique in terms of results?
I'm sorry, can you repeat that one more time, please?
Sure. Mike Black uses fuse sutures, and some other clinicians do too, and the question is, have you compared two suture techniques in terms of results?
You know what? I haven't done any cases the way that it's advertised. In other words, using that suspension type suture, figure eight suture to sort of support with an X the material or stabilize the material against the recipient site. To me, the reason I chose this approach was that I wanted to ensure that as many of these cells were approximating the wound bed, because the premise is that we're delivering growth factors and cellular components to a wound, and so it just made sense to me that the more I adhered this living cell construct to the recipient site with whatever means I could, maybe that would influence results. Now, I know that the company advocates using Copac and things like that to apply, apply pressure and stabilize further that material, which I don't do that. I actually don't use any wound dressings. I might have used one case. I think I used a wound dressing, and I don't think I presented it. I don't have the photos on that patient. That's the only reason I didn't present it. But for these cases, none of them had wound dressings applied, and so that's one of the reasons I selected this approach. Is I just find it's more comfortable for patients not to have that, and so this was an attempt to do what maybe Copac does, and that is to compress the tissue, compress the living cell construct, deliver as many active factors to the wound bed as can be done using adherence with sutures. So so the answer is, Mike, I didn't use those techniques, and I very well may do that in the future because it would certainly take a lot less time. I mean, you can imagine how long it takes to suture all those little 6/0 threads.
Yeah. Okay, and then we have a question and a comment combined from Rodrigo Neva. So he says, it looks like, first he says is, I'm sorry, I have to look at it. Why did you not treat the tooth as well as the implant? But it also, his second comment is, it seems like there was some gain in keratinized tissue for the tooth as well.
This one here?
Yeah.
The implant. Okay, let me see. Well, here's the pre-op. This is certainly not healthy. and I'm sure that I went in and scaled and replaned these teeth before we did the procedure. I didn't stretch. I looks like I might have stretched it. I think I probably did include the tooth in front to some degree. You know, I might have just extended it like so. I didn't take this picture. I have to tell you, I didn't expect this result, so I wasn't, and I probably should have, in hindsight, taken the photos intraoperatively. But I think I went, if you go back, probably from this line angle here till around there, and you know, I can't see where this ends, but it's probably around here somewhere. So if we look at this case and we say this is the new MGJ, you know, I don't know, it's hard to say if we gain something. This is still inflamed, by the way. But, you know, I probably could have gone forward here too and gained some augmentation of the soft tissue as well. But, you know, I was referred the case for a prescription type of procedure, and I might have gotten a little bottlenecked in my approach. But yeah, I would say, Rodrigo, I think that's probably a good idea, and I probably could have easily extended this further. And I try to be a little bit more careful about that type of thing going forward. And if I do see that there are proximal teeth involved, you know, I might make the case that, look, you know, I'm going in there, it's just a little further forward or further back. I've got the material, you paid for it anyway. I'll just involve that extra area, that extra tooth. So I think that's a good recommendation for this case for sure.
Great. Are there any additional questions? These are very interesting cases. You've had a lot of variety in what you've been treating. Any other questions from the audience? Okay, so Dr. Gottesman, do you want to do a little wrap-up, and then we can finish up?
Okay. Well, I just want to thank you all for your attention. It's nice to have my colleagues on board and give me some feedback, and it's a learning opportunity for me. I hope you all got something out of it, and I certainly did, and it's actually quite helpful to get up and do this, because it makes me more critical of what I'm doing, and that just makes us all better at what we do. So appreciate all of your time, all your questions and comments, and looking forward to seeing some of you at the next national meeting.
Thank you very much, and very interesting cases, and appreciate you showing what you've learned from it and a little bit of